الاستاذ الدكتور ايهاب. دكتوره هويدا لسه معانا؟
ايوه يا دكتوره ايمان.
طب يا ريت تشرفينا. عليكم السلام ورحمه الله وبركاته. دكتوره هويدا بعد اذنك تقدم لنا الاستاذ الدكتور ايهاب.
طبعا ليا الشرف ان انا اقدم الاستاذ الدكتور ايهاب. الحقيقه الاول بقول كل سنه وانتم طيبين ودايما كده ايام مثمره، وحضرتك كانت هايله يا دكتوره ايمان، وطبعا الدكتوره كمان. يسعدني ويشرفني ان انا اقدم الاستاذ الدكتور ايهاب الحكيم. حقيقه هو غني عن التعريف طبعا، استاذ الكلى، ودايما بنستفيد منه ومن علمه. اتفضل يا دكتور ايهاب.
بسم الله الرحمن الرحيم. دكتورة نهاد بعد إذن حضرتك ممكن تعمليني بوست عشان أقدر أعمل شيء. في البداية بشكر الأستاذة الدكتورة إيمان زكي على دعوتي للمشاركة في هذا الويبينار. والحقيقة بشكر الأستاذة الدكتورة هويدا الجبالي الأخت العزيزة على التقديم. وبحاول اتعلم الدكتوره ايمان بعض الفنون، يعني ده من تصويري. الدكتوره ايمان اختارت لي عنوان جميل: The Story of the Kidney and Psychiatric Emergencies. الحقيقه لما الدكتوره ايمان اختارت لي الموضوع ده انا قعدت افكر واتصلت بيها، قلت لها ايه هي السايكاتريك emergencies. فده اللي هبتدي بيه في الاجنده النهارده: Psychiatric Emergencies and Relation to Organic Condition. ثم psychiatric disorders in nephrology, Egyptian studies in pediatric patients, and finally we'll end with recommendations. To start with psychiatric emergencies and relation to organic conditions, I found this interesting review article published in 2013 about psychiatric emergencies, and it stated that the most prevalent diagnoses among adult patients presenting psychiatric emergencies were depression, adjustment disorders, and an anxiety disorder, comprising about 75% of this presentation. Psychosis, organic disorders, and addictive disorder were diagnosed in the remaining cases. In this review, they classified the relation between psychiatric disorders and organic diseases into three categories. The first category are psychiatric disorders causing organic symptoms. To start with, it is psychiatric disorder. For example, anxiety disorder, somatoform or psychosomatic and convergent disorders, and factitious disorders. The second category are psychiatric disorders or psychic disorders coexisting with organic diseases, comorbidity or dual diagnosis, and substance or drug use disorders. The third category is psychiatric symptoms resulting from organic diseases. The original condition is a medical illness, and this is reactive or somatopsychic disorders and pseudopsychiatric syndrome.
I'm sorry, like whose prescription was that?
Is there a problem?
الأستاذة الدكتورة سناء عبد الرحمن. أهلا بحضرتك دكتورة سناء.
أهلا
أهلا وسهلا. Good luck.
Thank you. In this review was classified into three parts. In the second part, they discussed the coexisting psychiatric and organic diseases, and they mentioned a list of drugs that manifest or can cause psychiatric manifestations. And reviewing these drugs, I found many of them in use in nephrology, like the cardiovascular drugs, digoxin, clonidine, methyl-dopa, beta blockers, ACE inhibitors, angiotensin II blockers, calcium channel blockers, diuretics, and statins. We always used all these drugs. Antibiotics, even quinolones, clarithromycin, amoxicillin, linezolid, and cephalexin. Immune suppressive drugs like corticosteroids, cyclosporin, tacrolimus, and cyclophosphamide. This review I can give you later on the chat or on the WhatsApp, the link for this review. They discuss the psychiatric manifestation present with every drug. In the third part, they discussed psychiatric symptoms resulting from organic diseases. And this I found very interesting. If we look at this table, we find that renal failure, uremia, may present with psychosis, depression, behavior or vegetative symptoms, cognitive defects, and cognitive consciousness impairment. They didn't mention here an anxiety, although it's common in uremic patients. I'm going to see just in a few minutes. The hypocalcemia also present with psychosis and anxiety, and the hypercalcemia may present with psychosis, depression, behavioral changes, and consciousness defects. Hypomagnesemia that we encounter in some tubular disorder may cause depression, behavioral changes, and cognitive defect and consciousness impairment. This highlights the relation between the organic and the psychiatric manifestations. We come to the second part, is the psychiatric disorders in nephrology. We all know that the definition of chronic kidney disease, or as we knew it in the past, is when the GFR is less than 60 milliliter per minute per 1.73 meter square for a period of more than 3 months. This is all known. But the new definition by the National Kidney Foundation KDOQI guidelines that we adopt right now in every study, there is another category important in which there might be not a decrease in GFR, although we have a kidney damage for more than 3 months. And this includes any abnormality in the composition of the blood or urine, any abnormality in imaging test, any abnormality on kidney biopsy. So with this definition, we might diagnose a case of nephrotic syndrome as a chronic kidney disease. We might diagnose a case of single kidney or vesicuroteric reflux as a chronic kidney disease, even with a normal GFR. This brings us to the nephrotic syndrome. The nephrotic syndrome, I want you to imagine this situation. You have a child, 4 years old, who is completely normal. He gets asleep, and in the next morning, he wakes up like this. What's the impact on his psychology and that of his parents? Okay, this is not enough. Next day, he wakes up like this. And within 3 to 4 days, he becomes like this. Okay, and his lower limbs are like that, with edema in very strange areas. He cannot walk, he cannot stand up. This is very shocking. They don't know why this happened. They come to the physician, he diagnoses the case, and he starts the steroid therapy, and after a month, he gets like this. This is not better, okay? But that's what we have due to steroid affection, particularly if the patient had a more prolonged course. Now, this is not the end. Also, he might develop such striae with the steroid therapy, and you can imagine the effect of these skin manifestations in particularly young girls. We start to shift from the steroids because of their side effects, and we give another drug like cyclosporin, and then the patient develops the gingival hyperplasia and the hypertrichosis. We are not doing good, at least for the psychology of the patient, and we don't pay attention to this at all in our management. We are looking for the urine analysis, the proteinuria, and what changes. Everything is going well, okay, but what about the psychology of the patient or the psychiatric manifestation and his parents? You can imagine. We come to the proper chronic kidney disease, or what we know previously as a chronic renal failure, particularly in dialysis patients. There are many causes for psychiatric changes among these patients. The uremic toxins, of course, and we have many of them. We are doing better now with the recent modalities of dialysis, hemodiafiltration. We are performing at least in 2/3 of cases in our unit. The hypertension and the drugs you use in treatment of hypertension, as you just mentioned, the disturbed body image due to poor growth or deformities. And I'd like to highlight the cooperation with the endocrinology who have started the treatment of such patients with growth hormone, and we are getting good results. The hospital dependency, imagine these patients, the dialysis patients, they are obliged to come to the hospital 3 times a week under any circumstances. I mean under any circumstances, okay? If there is a revolution, they come. If there is a bad weather, they come. Under any circumstances, they should come. Poor nutritional status, this is still encountered, but not among our patients due to the supplementation of meals on dialysis sessions and the cooperation with the nutrition clinic. Aluminum toxicity is historical, whether from the aluminum containing phosphate binders or inefficient water treatment. What are the manifestations of this condition? Lower scores on IQ, reading and mathematical testing, deficit verbal abstraction, visual motor abilities and memory, weakness during the day, either pre-dialysis due to toxins or post-dialysis due to hemodynamic changes, sleep disturbances, impaired self-esteem, and lower educational opportunities. The parents are not available for this school. They are overwhelmed with the hospital and the school absentees. Also, young adult survivors of the childhood onset and stage renal, when they become adults, they have fewer friends. They are less likely to participate in extracurricular activities. They are less likely to establish intimate relationships, and they have lower rates of employment and low occupational level. The parents of children with CKD are at risk for anxiety and stress, of course. But the interesting thing that the adult patients with end-stage renal disease since childhood are reported having an overall better mental health perception than those with adult onset end-stage renal disease. And this might be due to the plasticity of the brain that can occur in young age. Suicide is very important and usually not thought about in patients with CKD. This report in 2017 about suicide in chronic kidney disease is among adult patients, and they say that the CKD and hemodialysis are positively correlated. But in Pediatric Midwest Nephrology Consortium, the risk behavior in teens study published in 2019 says that the teens with CKD showed significantly lower prevalence of risk behaviors than controls. And certain patient characteristics were associated with increased risk behaviors among the CKD group, particularly substance abuse and alcohol. These data are somewhat reassuring, but children with CKD still need routine assessment and counseling about risk behaviors. This report review was published in British Journal of Psychiatry a few months ago, and it's about the review of emergency department interventions for children and young people presenting with suicidal ideation. And this is very important because we have reported in our unit since its establishment in 1991, 2 cases of suicide. One was intentional by the patient himself, and through drinking a huge amount of water, he got overloaded and pulmonary overload and heart failure, and we couldn't remove this overload in proper time, and he died. And the second one was a young lady who was underprivileged, and she committed suicide by jumping from the higher floor. And we had Professor Sahar with us in this situation. In this report, they say that the self-harm, which is the intentional self-injury without wanting to die, and frequently involves cutting, scratching, hitting, and drug overdose. This self-harm was reported among several patients within the age group of 10 to 18 years. And when they followed these patients for over a 5-year period, they noticed the occurrence of 44% among them deaths due to suicide. So it's very important sign, the self-harm. And children and adolescents presenting to the emergency department with suicidal ideation or self-harm should be considered at suicide risk. Have we performed any studies among our patients? Yes. This is a very old study. I think it's one of the earliest in Egypt among hemodialysis patients, and was conducted by our late dear colleague, Professor Iman Amin. And I think this is one of the earliest theses supervised by Professor Ihab about depression in pediatric patients on regular hemodialysis. And we used children anxiety scale and children depression inventory. And we found this very shocking finding. and anxiety was recorded in 100% of patients and depression in 71% of patients. Of course, both together in patients with depression. Not only this, but also we found sleep disorders, agitation, isolation, low self-esteem, suicidal tendency, and the non-compliance to drugs in many of the patients associated with the depression. And the majority of children and adolescents with chronic renal failure were depressed, and anxiety existed independent of depression. Under recognition of depression is a major concern. Treating depressed dialysis patients has received little attention. These were the conclusions of this work. Also in Mansoura, they studied their patients of CKD on hemodialysis, and they found significantly higher prevalence, 68% of psychiatric diagnosis, particularly anxiety, depression, and neurocognitive disorders. At the end, I'd like to recommend routine neurodevelopmental surveillance at regular intervals among patients with nephrology problems, particularly CKD, the recognition of early signs and symptoms of common psychiatric disorders, namely depression and anxiety, and early referral to therapy for affected individuals should be a routine part of the management program. Establishing special education service for better educational, emotional, and functional potential. A psychologist backed with psychiatrists is an integral member of any pediatric nephrology team offering either clinical, dialysis, or transplantation services. Incorporation of multidisciplinary approach, including individuals with psychosocial expertise into the transition program of adolescents to adult care may help maximize the success of patients as they aim to develop social and functional autonomy. Thank you.
محاضرة رائعة أستاذ الدكتور إيهاب، محاضرة رائعة. وعلى قد ما أنا ابتديت الفكرة علشان كل التخصصات تكون سمعانة والجونيور ستاف يبقوا دايما مايندد إن في ديفرنشال دايجنوزس واسع واسسمنت لازم يتعمل لكل عيان، على قد ما جمال وإبداع كل حد ابتدى زي نهاد وحضرتك في إنه يعمل هايلايتنج للسبجكت اللي هيبقى اعتقد انه هيبقى يعني ماستر بيس في نهايه الويبينار ان شاء الله. بدعو الان الاستاذه الدكتوره ايمان